Okay, no problem. I'm just setting up the case right now.
Okay.
So this was a 28-year-old male who came to us after being imaged at an outside institution, and the uh, the pertinent history for this patient is that he's a bodybuilder and he was using anabolic steroids. So any thoughts from anyone?
Adenomas, Ben.
Yes, yes. So that's what they were thinking at the outside institution. Um, Unfortunately for this patient, I think there was a there was a decision made to biopsy the largest lesion, and when they biopsied
Ben, I
this
have a
lesion,
question.
yes.
On the coronal there, I see like some central enhancement, like a little central dot kind of thing. So one other thing that comes to mind is peleosis.
So that's a very good thought. I a lot there's quite a number of lesions, and um, most of the lesions demonstrate this hyper enhancement and washout on portovenous. I see what you're saying about that that lower lesion down here, um, but we were thinking maybe it's
Yeah,
like
that's
a little bit of
unusual one.
right. Maybe it's a little bit of an unusual presentation of the entity that we were thinking about. But just to give more context for this patient, we actually before the patient came to us, they ended up biopsying this lesion in hepatic segment 3, and there was a little tiny um, post-biopsy hematoma um, just distal to their biopsy. But unfortunately for this patient, the biopsy results came back as HCC, and this actually was an interesting case that I ended up presenting in tumor board. Um, we're having the biopsy reviewed at our institution, but if our pathologists agree with the outside pathologist that this lesion represents HCC, um, this patient would have a personal history of HCC. And I actually had an opportunity on this case to get a consultation from Dr. Victoria Chernyak, who confirmed that LIRADS would then be applicable to the patient given that personal history. At this patient, initially, without the pathology information, the liver did not look cirrhotic. So we were thinking, as you guys mentioned, we were thinking that they were multiple adenomas, possibly the beta catenin adenomas that are um, sometimes seen with anabolic steroid use, but obviously those can have uh, transformation, and we follow them because sometimes they can become HCC, and they can become malignant. So this was an interesting case that I wanted to share with the group. And then
And I have a question. For the HCC biopsy, and maybe they haven't looked at this yet, but like, do you know if they can tell if it arose from an adenoma, or like, was there
so
any discussion about that?
that's something that we were interested in during tumor board, but I don't think they know. Just the pathologist report mentioned that the sample was consistent with HCC, but did not comment on um, whether there was features of an adenoma present as well. I'm just gonna close this for a moment to pull up the second case so that I can share it with you guys.
I had a comment on that case. I think it will be nice to get a pathologist opinion on that, because from what I know, even pathologists have hard time differentiating adenomas from well-differentiated HCC, which actually is a complication of an adenoma, especially more in beta-catenin subtype. So
That's
I'm trying to say,
absolutely
it's
a
not
valid point.
surprising if you get results of HCC when you're thinking that you're biopsying an adenoma. Large adenomas often will have malignant transformation.
Ben?
Salient features. So you can see that there are these multiple lesions. And what would you say about the liver?
Like cirrhotic and with, multiple lesions. And
Could be pseudocirrhosis. Does the patient
Yeah,
have?
it kind of reminds me of that case I showed at SAR last, right?
Right.
Where there's an overlap in the appearance between cirrhosis and maybe a person who has metastatic disease and actually pseudocirrhosis.
Right. So this woman came in, actually obviously don't remember why, but you can see the diffusion was on this case. I'm not even going to show you because it was such a bad quality, but you can see on T2, it has a very, very kind of target-like appearance, right? Similar to, I think Steve, you had something similar in your case. And, all these masses are kind of intermediate signal intensity on T2, as Aarti likes to say, the evil gray of tumor. And, they're kind of hypo-intense on pre, and we'll give contrast, they're primarily hypo-intense. And there's a lot of kind of overlying parenchymal, not parenchymal, capsular retraction. So, with this appearance, we may think about cirrhosis with diffuse cholangiocarcinoma or some sort of metastases, and some hard. It's hard to distinguish between these. So this was biopsy, and this was indeed was breast cancer with a serous component. So that so this was, and this was not treated. This was de novo, just very serous component to the tumor. So usually we see this after treatment, but this was actually before treatment was ensued. So the next case.
Victoria, I have a question about that. And not really about that case, but say you have a patient and they look like they have cirrhosis, or maybe on the verge of that, but they have no history of hepatitis or anything like that.
Right.
When can you still use Lyrads if you, like, how convinced do you have to be that they have?
You can do it so provisionally. So for example, you can say, like, sometimes obvious, the signs of cirrhosis are obvious as portal hypertension. You can be pretty confident that the patient has cirrhosis. Then you can say, morphologic changes of cirrhosis, Lyrads, whatever. If the changes of cirrhosis are questionable, if you're not sure, but you think it may be, then you can apply Lyrads provisionally and say, if the patient is confirmed to have cirrhosis or other factors, risk factors for HCC, such as hepatitis B infection, then the lesion would meet criteria for Lyrads 5 or whatever, Lyrads, whatever. In absence of such risk factors, the differential diagnosis is blah, blah, blah. I mean, that's how usually we handle it.
Okay, thanks.
Okay, so the next case is not liver, shockingly. But we have this nice, well-defined cystic mass in the pancreas. You can see that there are like a lot of septations internally, and it's hypo-intense on pre-contrast, and then this is what it looks like when we give contrast. So any thoughts? And I'll show you the delayed. And here's the delayed.
I have some thoughts. I want people to speak up in the chat or speak up.
Let's see. You're monitoring the chat, right?
Yeah.
Okay.
Nobody's speaking up. Okay. Christine,
would,
yay.
Like biopsy this, but in my differential, I would include cystic neuroendocrine tumor, MCNs. And I don't like some kind of additional pancreatic. It doesn't look like an adeno.
Right.
I think acinars are a lot more solid looking and more infiltrative looking. Spens are not so cystic, but they can become cystic in some situations. So
Again, a couple of people in the chat, Christine and Amar, voting for SPEN.
Right. Okay. Somebody asked for pre-contrast, and here, give me a second. And here's the pre.
And do we have demographics?
This was a female, clearly. She was older. She was not a teenager. She was older. So this was, so this, I agree with Nella's differential. I think the differential we provided, we favored mucinous cystic neoplasm, and we threw in the cystic neuroendocrine tumor. And one thing that kind of stood out here for the cystic neuroendocrine tumor is because on the delayed, it almost completely enhances, right? So this was was taken out, and this was a cystic neuroendocrine tumor. And I have to say, this is the only neuroendocrine tumor that I've seen that was this cystic, that it really truly mimicked a cystic neoplasm, rather than, like, it was hard to see that this is just, very necrotic tumor.
Yeah, Victoria, I agree, because MCN usually, even if it has a solid component, wouldn't have this much solid
Right.
without and have those little cystic spaces. Cookie had a good point, which is why she wanted to see the pre-contrast, because usually SPENs are hemorrhagic, and this one was not T1 bright or hemorrhagic on the pre-contrast.
Great.
And then Cookie is also asking about gastric fold thickening.
Honestly, it may be. Every time I think it's thickened, it ends up not being thickened, or just under distension, or
Easy to overcall that one.
I always either overcall them or undercall them. This was not in the men's setting. It was just DWI. Un momento for DWI. Here you go. So, I mean, this is again from 2014, so the quality of DWI is not as nice as it's now, but I guess there's nothing obviously restricting. But it could obviously be true thickening. But if I
Cookie is saying that's real. I think she's saying that's real thickening, but I think in the setting of PPIs.
I won't argue with Cookie. She knows. All right. So the next case is a really nice case, but really it's a really old scanner. So kind of bear with me in terms of quality. So here's the coronal, and you can see there's a mass here, kind of with a funny kind of peripheral appearance. There's additional mass kind of hanging off the liver. There's something in the liver, and then there's something with like these swirls in the peritoneum. So just based on this is, again, the reason I'm saying this is such an old case, that this is a T2 weighted sequence, but you can see there's a lot of dielectric effect, and the signal is just dropping away. But there it is on pre-contrast. I mean, on the post-contrast, you can see. So you can see these big things, big lesions. So any thoughts?
Any history of travel?
Well, not necessarily as much travel as she's an immigrant. She was an immigrant.
Yeah, Kedar, why are you asking about travel?
I was just asking for hydrated.
Yeah, I was thinking about that too.
Right.
I'm looking like on the chest, the pulmonary one almost looks like it has little daughter cysts along the edge, at least on the T2, it looked a little bit.
Right. So this is exactly what it is. This is an example of hydatid on MR. And so these are the daughter cysts. There are some sequences we kind of sort of see it a little better. And interesting case here, you see these are the daughter cysts. So you can actually see different kind of stages of hydatid, or we would if the quality was a little bit better. But you can see here these kind of like membranes within the bigger cysts right there. So just quick, interesting that there are several stages of echinococcal, and actually the CL very, very early stage just looks like a simple cyst. And again, they can look really, really like a simple cyst. They can have septations. They can have these spochial appearance. They can have these water lily sign, which is one of the ones that we say we saw kind of this swirly stuff. And then once it gets into inactive stages C, 4, and 5, it can have pseudotumor appearance, and it can be completely calcified. So just some examples. This is the simple cyst, and then these are the CE2, which is within the daughter cyst, and this is the ultrasound version. Again, simple cyst, and then these water lily detached membranes. This is a degenerating membranes, and they can actually mimic the pseudotumor. So some of these kind of findings you can, if you look carefully, we can sort of see in this case. And she was operated, they took everything out. More?
Yeah, sure. And also Cookie recommended a radiographics paper. I'll put it in the YouTube notes, but I'm looking at it and it looks really beautiful, especially these diagrams and stuff. It looks very comprehensive.
Okay, I'm gonna show this case, but probably Steve was gonna help me here. So this was a relatively young woman came in with a lot of abdominal pain and vomiting. And you can see here's the stomach. And as you follow it, it kind of makes this funny twists, comes here, and then just kind of swirls this way. You can see that the antrum sits kind of close to the, see right there. So this is where the antrum kind of swirls around. So any thoughts? Yep. So this was mesenteric axial volvulus. I think this is the only one I've seen on CT. I've seen organoaxial, that we see them with association with, with large HH, not that infrequently, but this is the actual mesenteric axial volvulus where the twist is kind of, like you can see here, it's instead of, with organoaxial, the greater curvature goes up and just the entire stomach kind of flips up. This one is a true twist, and you can, and this is how you know where the antrum kind of sits close to the G junction. So, and this one needs operation, true kind of emergency, where organoaxial can be just left alone if there's not symptomatic.
So I think my audio is working. It's Cookie here. Can I just have a couple?
Please do. Hi, Cookie.
So, when you have the large diaphragmatic central hernia and you have the stomach, you being in intrathoracic cavity, the stomach can flip on its long axis, and we call that organoaxial rotation or organoaxial positioning until the stomach wants to descend down. And when it descends down through the diaphragm, that's when the organoaxial obstructs. It's a different way of thinking. The organoaxial actually obstructs as the stomach wants to descend down. Very different than mesenteroaxial. In fact, the vast majority of mesenteroaxial volvulus are below the diaphragm. They twist below the diaphragm frequently in children. But that's one of the key things that was kind of a hole in my learning, where I thought all of them obstruct through, above the diaphragm, and that's incorrect. So that's just kind of my teaching point there.
Cookie. So this one is below the diaphragm, so that fits with the mesenteric axial.
Cookie, I have a question for you about what you said about the gastric wall thickening and the setting of PPIs. Like, how did you feel so certain in that last case that was real gastric wall thickening and it was related to PPIs?
Because I've started doing a complete search, a retrospective search on this, just for my own learning on when to call PPI and when to not call PPI. I guess from my standpoint, it was an internal audit for me.
And you feel more confident that it wasn't just under distended because it was like there was enough distension, but there was still a significant amount of thickening.
Yeah,
it
wasn't completely collapsed. It had fluid in there. I mean, it wasn't as distended as this, and it was more that it was involving. I kind of wanted a little bit more diffusion. Usually they're a little bit prominent, not high B, but B, mid B. It usually does have some signal on it. Yeah, involves the entire fundus on it. And then, invariably you'll see many of these neuroendocrine around PPI. There's some not necessarily the ones that are secreting, but that's also been an internal thing that I've been looking at. But anyway, we can go through some of the studies on it, but we are actually presenting PPI related changes and the imaging features and how good and how bad we do. So we're looking at that in Mayo with a former fellow and myself.
Cool. Thanks.
More?
Yes.
This one. Oh, this one's interesting. So this was HCC screening. Does anybody see anything that is bothering them on the images that I'm showing? I'll just put in the
Swatch on the says free gas, free air.
yeah.
Yeah.
So this is probably the most starking example of free air, unexpected on MR that I've seen. You can see this is non-dependent kind of black signal void. You see it on T2 and T1. There you can see it nicely on T2, just right. And then patient had chest X-ray and voila. So this was unexpected. I don't remember why they had this much free air, but this is how we picked it up on MR. More? I have one more.
Okay, go.
Okay, so this was another liver case, and patient. So you can see that there are these kind of very ill-defined lesions, right? T2 kind of intermediate to slightly high. You can see that they are restricted in diffusion. And when we give contrast, some of these have sort of ring enhancement, some have ill-defined, just uniform enhancement. So anyone has any thoughts there? You can see they become kind of much more ring looking. Any thoughts? And here's the pre, just kind of very hypo-intense. Okay, so right.
Gitanjali is saying neuroendocrine Mets.
Right. So
we can also think about microabscesses, but they look a little too extensive, too many solid ones.
Right. So right. So MATS is probably the first thing we're going to think about with this appearance. Some sort of weird microabscesses could be. And this often there's no, and the restricted diffusion is really not helpful to differentiate. So this was biopsies, and this was sarcoidosis. So this was a very unusual presentation of sarcoidosis. Usually sarcoidosis in the liver kind of has a more infiltrative appearance. Sometimes it just kind of this creepy signal intensity through the liver. I've seen cases where it just creeps along the portal trads, but in this case, these were just discrete granulomas in the liver that had this appearance.
Victoria, you showed, I think, last week some sarcoid, right?
It's feasible.
I'm just wondering, like, do you ever bring it up in your diagnosis these days, or is it still like a diagnosis of exclusion?
I mean, honestly, when I see things like this, I just give very broad differential and say, could be, neoplastic, infectious, or inflammatory, including sarcoidosis. Because a lot of times you just can't tell them apart. So, right. Sometimes you can get an idea. Sometimes you can see some other signs that pull you somewhere, one way or another. But a lot of times you still have to biopsy these. So that will be it.
Nice. Gitanjali?
Yes. Just 2 quick cases. And I also have one consult case. I don't have the final diagnosis on it, if you all can see and tell what you all feel. Okay, can you all see my screen?
Yeah.
Okay, so she's a 54-year-old lady who presented with spontaneous intra-abdominal hemorrhage. We did a CTA on her. So this is the pre-contrast. This is the arterial phase. The findings so far.
It looks like a lot of it is affiliated with that left kidney, like a subcapsular almost hematoma, but then extends into the retroperitoneum. And then,
Or something in there. Or,
yeah, I was looking at the vessels in the hilum there. Like an aneurysm. Amr saying left renal pseudoaneurysm.
can you magnify or zoom in or make it one full image? Yeah, they like that.
Yeah, it looks like there's a pseudoaneurysm on that left kidney.
Yes.
And Cookie saying Wonderluck.
What is that? I don't see the chat box here. So yes, there is perinephric hematoma. There is a renal artery pseudoaneurysm. There's something in the liver too. And then there were hepatic artery pseudoaneurysms as well. And there was some other piece of history that still not disclosed, but this on imaging, there are some findings, additional findings. She didn't come to us as a known something, but there were some findings on imaging that suggested that she has some underlying systemic disorder.
Okay, we've got some guesses here. Amr saying Azur Weber Rendu, and Cookie saying Pan.
Okay, so she has these skin nodules.
Ooh, neurofibromatosis.
Neurofibromatosis. And then we looked up, and neurofibromatosis is associated with vascular dysplasia. So these were pseudoaneurysms associated with NF1. And something very similar, like what I had read, is like we have multiple visceral artery aneurysms. Yes, PAN is a good diagnosis, but doesn't cause so many SMA branches aneurysms. I think it more involves kidneys and lungs. But segmental medial arteriolysis is one thing where you can get splanchnic artery or mesenteric artery aneurysms. And then there are some systemic disorders like Marfan's, Ehlers-Danlos, neurofibromatosis, where there are vascular dysplasia is associated and can cause multiple artery pseudoaneurysms. So this was a case of NF with vascular dysplasia and had multiple pseudoaneurysms that were embolized. And then the second case is also a companion case. So that's the clue. Oh, sorry, the findings was. So they have a mass here. That's the finding. And then I'll again scroll the images for the rest of the findings.
So, yeah, I see lots of subcutaneous or cutaneous nodules in this patient.
Yeah, so this patient is also NF. So this soft tissue mass, what would be your thoughts on this one?
Cookie saying NF with GIST.
Yes, yes.
Increase
Yes,
rate.
so this was another common association with NF. I think this was read as schwannoma for some reason because this patient had history of neurofibromatosis, but just probably are more common mesenchymal tumors, bowel-associated mesenchymal tumors in these patients. And we often talk about abdominal manifestations of VHL, tuberous sclerosis, but not as much with NF. But these were the two common associations that we can see with NF is vascular dysplasia. And if they have small bowel tumors, just are the most common ones. And it looked like just like it's more solid. Schwannomas will be more hypodense. They look cystic, more cystic, and they can get pancreatic bed schwannomas. The other tumors that they'll get are neuroendocrine tumors, paragangliomas. So just some of the common manifestations with these syndromes. Okay, so these were my 2 quick cases, and this is the consult case that we have. So this is again a middle-aged male who presented with abdominal pain and had this abnormality on CT. So this has been biopsied twice, and both times the biopsy came as non-diagnostic, I mean, mature fat, and it's expected, right? They probably got mesenteric fat, and that's why the biopsies showed mature fat. One of the differentials were liposarcoma, so they did MDM2 and it was negative, and it doesn't look like a well-differentiated liposarcoma. They usually have more septations, and the appearance of the solid nodules is also different in those cases. So any thoughts on this one? And we also have an MR. So MR is interesting because you can see that the signal in these, what we thought were solid nodules, is more fluid-like, cystic.
I had a case that was lymphangiomas in the mesentery that looked something like this. Ours was more extensive.
Okay. Yeah, I think.
Mesenteric lympangioma.
Yeah, Steve, I remember your case.
Remember that case? Yeah. They treated with an unusual
TK inhibitor, right?
Yeah, exactly.
Okay, so you all agree with lymphangioma. I think that's, yeah, Dr. J read this out and he called this as lymphangioma. But how can we confirm the diagnosis? Like, should we recommend a repeat biopsy? Because
you already said you did 2 already?
Yes, 2 biopsies have already been done and showed mature fat.
I think they might have missed it. I mean, ours was biopsied and they were able to make that diagnosis. I can't remember if it was an open biopsy though. Sometimes they have to go in laparoscopically and grab a little chunk of stuff rather than trying to do something percutaneous.
Okay, Cookie says resected. Okay, we'll talk to the surgeons about it and let's see what they say. But yeah, thank you all for your input. Really appreciate it. And that was all from me. Stop sharing.
So Steve, I just Googled from our website. You presented it on September 10th, 2018, a day to live in infamy. And you said it was treated with a PIK3 tyrosine kinase inhibitor. Right. And I remember your case like really shrank away.
Yeah.
It was like amazing response.
Yeah, it started like a huge mass and then they ran the tissue that was, I think it was an incisional biopsy. They were thinking about resecting. They went in, it was like too extensive in the mesentery. No way, we're going to get this thing out. Took a piece, gave it to the pathologist, saw that it with foundation 1 or something had a potential target. And then they did that TKI and it really responded.
Yeah, I remember, Cookie, you sent me a case where like you guys had like the entire pathologic specimen. And yeah, she's telling me in the chat, remember, I have the case. But when but the fact that it can respond to these inhibitors to me suggests that maybe you don't need to do this extensive resection. I think maybe even like surgical biopsy and like if one more percutaneous biopsy really targeted at that area can't get it. I don't know. I personally probably rather biopsy it and treat it.
Can you hear me? This thing is going in. The case that you showed me as a consult member, and I sent you that, it was 2 exact same things. Both went to surgery for resection, but they were huge because these they can grow and be infiltrative. So yes, they do treat it. I just meant resect as in take a bigger piece from surgery for tissue diagnosis.
Cool. Okay, I have a few cases. Let me try to see if this will work. Okay. So this patient is a trauma patient, and I'm going to try to monitor the chat, okay, on my phone, so hopefully it'll work. You can see that they've already actually gone to surgery. They had a bullet. You can, the bullet is right here. The bullet went through their lung base, their pericardium, their diaphragm, and their liver dome. They've already gone to surgery. They went basically straight to surgery where they did an exploratory thoracotomy, and then they saw the diaphragmatic injury, and then saw the liver injury, and then basically went into the abdomen because they'd already done a median sternotomy. And so they were able to easily go into the abdomen. And they saw this large laceration of the liver, which they graded as a grade 4 liver laceration. On this post-operative image, you can't really see the vessels. It's not the best phase for the vessels, but it did not seem to be involving the portal veins or the IVC. So it was not to the level of a grade 5 hepatic laceration. What they did was they evacuated all the blood here, and then they laid down both Surgicel and then something they described in the operative report as snow, which I had to look up, but apparently it's a new type of Surgicel. So Surgicel is a hemostatic agent that has antimicrobial agent on it that can even attack multi-drug resistant things like MRSA. But snow is a even more effective one that is made by some of the same people. But basically it's a new agent that has collagen in it that allows platelet network to be set down. So it stops bleeding like 43% faster. So anyway, long story short, they placed, and it's only one layer of material, whereas Surgicel, they often do multiple layers, which is why we often get multiple layers of gas forming. That is kind of like classic for Surgicel. So this was Surgicel and snow in this large liver laceration, and this was immediate post-op. So 1 week goes by, and they decide to re-image the patient because they were having abdominal pain. Steve says lots of similar findings with lots of bioabsorbable fillers, mimics abscess. Yes, exactly. So yeah, you can see it could be mimicking abscess, but we know that, this looks like it's very packed together. This is probably Surgicel or the snow material. There's a hematoma around it. But do you guys see any other findings now? This is 1 week after post-op.
There's some active bleeding around the periphery.
Yeah, so there were actually multiple small pseudoaneurysms. And Swachanda also got it. So let me just narrow this a little bit. So they were maybe even this one, but kind of, and then this guy right here. And then higher up, there's even more. So there's this one, this thing, that guy, this guy. So basically lots of pseudoaneurysms along the edge of this large laceration. I couldn't really figure out why that is, that, they're forming so many pseudoaneurysms. But in the literature, I found that if you have a hepatic injury, there is a risk of forming a pseudoaneurysm in a delayed fashion. And it happens mostly with patients who have a grade 4 or grade 5 laceration. And there is an argument for doing a post-op scan, especially before somebody gets discharged. If you're doing either non-operative management of both a splenic or a liver laceration, especially when it's this extensive.
Sorry, the bullet, it was just in the subcutaneous tissue, or did it penetrate and go through? So it wasn't a through and through injury, right? Because we can also get ballistic injury, surrounding the tract of the bullet that causes delayed injury, ischemia, and possibly vascular pseudoaneurysms.
Yeah, that's probably what happened here. It was basically went through the liver, through the diaphragm. I think actually the trajectory came from above and then down through, and then the bullet ended up back here.
Gotcha. So it's probably a field effect from the ballistic wound.
Yeah. So that induced these pseudoaneurysms. When they went in, they did what they called a hepatography. So basically they stopped all the bleeding that they could see. And then they sewed up the hepatic defects. And that post-operative scan did not show anything at that time, like any of those pseudoaneurysms at that time. So they didn't go to angio immediately, but 1 week later, when we found all these small pseudoaneurysms, they went to angio. So Cookie's saying grade 4 with hepatic vein involvement requires angio. I don't know. At the time they did not think, I can't really tell from this post-operative exam if there's hepatic vein involvement. But you think you should have gone straight to angio here. I mean, there were no pseudoaneurysms that we could see at this time here. It's not, and it's not the hepatic vein that's extravasating here. Okay, so Cookie's saying they should have gone in for damage control at this time. Okay, well, they went in 1 week later when they found all these pseudoaneurysms, and then this is the post angio, and you can see that the laceration is it's an evolving hematoma. The Surgicel is now evolved so that we don't see any more of that air in it, and we've got all these embolization coils, and they coiled 3 of the vessels. Okay. My next case is this one. This is a well circumscribed fluid filled lesion. We would probably all say this looks like a hepatic cyst. And then about 6 months later, it looked like this. I'll show you some more images. So that's the T2.
Bigger.
And there's some mass effect too, it looks like maybe. There's this rind.
A rind, is that what you're saying?
Yeah.
Yeah, exactly. I think there's like a little bright rind here. There's a little bit of like fluid adjacent to the liver, and the
and there's like a layering.
Yeah, good. There's like a layering there, and this is the coronal. Rupa saying fluid level within. Yep. And then
did you show us T1?
Contrast.
There's post contrast T1.
Yeah, this is post contrast. So we still see that rind with a little bit of fluid. I'll show you the diffusion.
Not the classic location, but ciliated foregut cyst.
Good thought. So this is the DWI, and then this is the ADC.
Patient's not infected, are they?
Yeah, so and Amar's saying hemorrhage. And so this is this was kind of the question for us. Like, for example, it got bigger in 6 months, right? So it looked like a simple cyst here, and then it turned into this here. So we were kind of talking about it like hemorrhage can restrict diffusion, and infection can restrict diffusion. One of the things for an abscess that has been described is if you have like peripheral, very, very dark ADC, that's something that people talk about with abscesses. This was dark ADC, like kind of layering within it. So this was they put a drain into this and it was infected. So this was just superinfection of a cyst. And we were saying that we thought that probably this restricted diffusion was kind of like all the pus layering within it. So just kind of an interesting case of like a spontaneous superinfection of a previous cyst. And Rupa is asking if there were any risk factors. There is this risk factor in that they've had a partial hepatectomy. And so they have a hepaticojejunostomy. So anytime you have that bile duct to small bowel connection, you have like reflux of small bowel juices into the liver. And so you can get more likely to get abscesses.
Aarti, can we look at the arterial phase on MR? Do we have that?
Mm-hmm.
Yeah.
I'm glad about this active chat. I can barely keep up. Okay. I have seen, okay. This is the arterial phase. Not that much hyperemia around it.
I was looking for infection. We rely so much on adjacent hyperemia, but it's maybe chronic or.
Yeah. I think also like some infections can be a little bit more indolent. They don't have as dramatic of hyperemia around it, but yeah, it was interesting. And somebody's asking if there's a pleural effusion. No, there is no. There's a little bit of atelectasis. There was elevation of the right hemidiaphragm. I don't know what the bug was. I can look it up. When somebody else is presenting next, I'll look it up. We had a similar one. Patient was on steroids from polymyalgia. So these can get infected. Yeah. I think in this case, the patient wasn't acting super infected and like very infected as far as like symptoms, but I've seen that a lot with hepatic abscesses, that they can be more indolent. The patient might just say, I have had vague pain for like a month or two. They might not be like, have such a white count, but it actually could be an abscess. So. Okay.
Can I present that case from earlier?
Yeah, let me just, do you mind if I just finish?
Sure, of course.
Okay, this one is an interesting one. I have to try to not share anything with this pet, but basically this patient had breast cancer that was pretty extensive. So this was their breast cancer, but they have extensive, very avid lymphadenopathy in the left axilla. And then there was a mass down here in the pelvis. You can see that this mass in the pelvis was not as avid as that axillary lymphadenopathy. And it looked like this, which to me looked very weird for like a breast cancer met. There were ovaries. I thought that looked separate from it. I didn't, but you know, I guess anything's possible. So we have this mass in the pelvis. They got an MRI. This was actually an MSK MRI. And then you can see that there is this T2 bright mass. It actually has some fluid levels within it.
Lymphangioma?
Maybe it could, that's a great thought. I'll show you between the pre, this was pre, post, you're getting some kind of blobby enhancement. So that would kind of go less for lymphangioma. And then by the, this is the most.
Separate the adnexa from this thing?
Yeah, we thought the adnexa was separate. Go back to the T2. Oh, it's not included here. I'll tell you in the end, this was not adnexal.
Okay.
Yeah, and it was T2 bright. It had these fluid levels. It had blobby delayed enhancement. And it was not the ovary. So any other thoughts?
Angiomyxoma.
Good thought. And especially we had one like that last week. I was thinking about a solitary fibrous tumor as well. Christine, I like your idea of about a hemangioma, especially with these fluid levels. It almost reminded me of like an aneurysmal bone cyst. I was like very confused, but it was having a lot of enhancement.
I would have said maybe it's some sort of angiomatous tumor.
Yeah. Okay. So months go by. So that was, so 6 months later, patient is on chemo for their breast cancer at this point now. And
They just left this in place and watched it under chemo?
Yes. And so I'll show you, it's very interesting that the mass moved. So now you can see, even though it was very low down, like almost abutting the uterus before, now it is in the right upper quadrant and completely separate from the uterus. So this was like a mesenteric mass and it's completely moved into the right upper quadrant and it has decreased in size.
Was it like an omental infarct or something?
Nope. It was biopsied.
It doesn't look like fat.
Nope. And it was still enhancing. Okay, Cookie saying fibrous pseudotumor. Good thought. I don't know how those might respond to chemo, but actually my surgeon got this correct. And I was still going down the solitary fibrous tumor route that had responded to chemo. Amr saying lymphoma, nope. So anyway, this was biopsied and this was a GIST tumor.
Wow.
So one thing to think about, like if something's bopping around the mesentery and we think it's mesenteric, like a lot of times something that appears mesenteric might actually be attached to the small bowel. GIST would be much more common than some rare mesenteric tumor. So, so my surgeon got it. And yeah, this was a GIST. And I don't know what it was about this GIST, but something about the chemo they were giving for the breast cancer was also causing the GIST to shrink.
I mean, I usually include GIST in any mass that's near the GI tract when it's complex appearing.
I know. I don't know why it didn't occur to me. I was just like so bent on solitary fibrous tumor. And anyway, because of this T2 brightness and the blobbiness and whatever, but yeah, he got it. So cool. And then I just want to show this one quick case because actually it's complementary to Victoria's case from today. This is a cystic mass in the pancreatic tail. You can see it's got like this smudgy stuff in it. This was the right there. This was the venous. So it basically enhances quite a bit. It has a little bit of T1 hyperintensity. And it's enhancing. And this patient was a 19-year-old female.
And a spin.
What'd you say?
Spin.
Yeah, was that Gitanjali or?
Yes, that was me.
So actually you
I first said neuroendocrine tumor, but when you said 19-year-old female, I changed it to spin.
I know, I trapped you. So basically, so I was thinking the same thing, like, oh, she's 19, it's gonna be a SPEN, it's maybe even got some T1 hyperintensity, it's got a bunch of enhancements, SPEN. But anytime, now I've been fooled enough that like when I say SPEN, I also bring up neuroendocrine. And so this was resected and was a cystic neuroendocrine. So just because patient is 19, do not, cystic neuroendocrine or neuroendocrine in general can affect anybody. And then a couple of teaching points about cystic neuroendocrine. They actually have a better prognosis than regular neuroendocrines. So if you see these cystic changes and if the patient is in an active surveillance category, which surgeons are now using, some surgeons use 2 centimeters, some use 1.5. The cystic component can actually make you feel more confident that this is going to be a more indolent tumor, a less aggressive one. And these are also usually non-functional. So they're usually incidental. Any other questions? Okay. Ben, do you want to go?
Yes. So this was a very interesting case that we read here. And there's 2 examinations separated by about 2 years. The initial examination was this one. And there are these lesions in the adrenal gland in a young female that are T1 isointense, T2 isointense, demonstrate some heterogeneous hyperenhancement and restricted diffusion. In the interval from this first examination to the second examination that we have here, they actually ended up surgically resecting this right adrenal lesion. So we knew what this was when we were reading this. They have these 2 lesions, the right and left, have exactly the same signal characteristics. But after we ended up reading this examination, I actually was able to go and see an article from our colleague, Dr. Sandra Segarin, and he actually ends up talking about this entity in his article.
Ben, there's a request for you to scroll.
Oh, sorry. Yes.
I've got a little lost along the way. I see a left-sided mass.
So there's a right-sided mass here, and there's a left-sided mass here. These are 2 separate exams. So
we don't see you scrolling. Maybe you're sharing a different screen. Okay, now you're scrolling. Okay.
Not sure if you guys are able to.
Can you scroll the coronal T2s so that?
Yes. So this was the T2 from our exam.
This is a post resection.
This is the post resection. I was trying to share. Both of the screens, but since that's not working, I'm gonna grab it and bring it here. This was the pre-resection masses. I actually have it open in front of me, but for some reason it's not projecting. And as I mentioned, these 2 examinations were about 2 years apart, and an interval from this exam to the second exam, they actually ended up resecting this right adrenal lesion. The imaging features of the lesion were T1 isointense and T2 isointense to the liver with heterogeneous enhancement and restricted diffusion. This was an entity that I came across in this case, and actually went back and read a little bit about it in Dr. Sansegaran's article, and it's an oncocytic adrenocortical neoplasm, and these can be, as I mentioned, T1 and T2 isointense with heterogeneous enhancement and restricted diffusion, and should potentially be included in our differential for large adrenal lesions.
Are they benign or malignant? Like, when we think about renal oncocytoma, we think them as benign. Like, what's the prognosis for the adrenal ones?
So in the article that I read, it mentioned that some of these have a benign course, but they are surgically excised because we can't tell them apart from the malignant lesion. So the oncocytoma itself, it's kind of similar to a renal oncocytoma, where the underlying lesion is actually benign, but it can have some focus of malignant transformation within it, and they're surgically excised because of that reason.
And then Christine asked if they're commonly bilateral.
This case was, I'm not sure if they're always bilateral.
Yeah, I think I actually presented a case here at this conference of this same thing, which I was not aware of before I had my case. And what I learned was that it's on the spectrum of like uncertain malignant potential. So they're benign tumors, but you still have to resect them because a very small percentage will harbor, I think, like a adrenocortical carcinoma or some dysplasia within it that can go towards that. But generally they are benign. And this is an amazing case. I can't believe, because they're so big, but they don't aggressive like an adrenocortical carcinoma. So it's like mysterious, but it seems like maybe we could bring that up in the differential, but they would still have to resect it.
Absolutely. I got very lucky that I read this case.
So are they planning to go back and resect the left-sided one now, or are they kind of like, oh, this is a benign thing, we can watch it, or?
So the last note that I saw didn't mention anything about surgical resection. This case is within the last, it's a recent case, so they may choose to do a surgical resection. I know that they resected the right-sided one because of its size and kind of the mass effect that it was having on adjacent structures. But since that was benign, I haven't yet seen anything in the EMR that mentions that they're going after this left lesion.
Yeah, and Cookie brought up oncocytic ACC, and so this case was not an oncocytic ACC, it was an oncocytic neoplasm, right?
This was an oncocytic adrenocortical neoplasm of uncertain malignant potential, but Cookie is correct. They can have a focus of ACC within it that's not easy to appreciate on imaging, and when they get large like this, they are surgically excised.
Cool.
It was a very interesting case that I wanted to share with the group. That's all I have.
Thank you, Ben. Thank you, everyone. We will see you next time.
Thank you all.
Thanks.